Good morning, Samir.
Fine, and you?
How nice to see you.
Yes, it's the same.
So I guess we are all virtual.
Yes, we are virtual.
Yes.
Maybe we always have been virtual. We didn't know. We always thought we are physical, but we are not. Right. We are just a fake.
You
know, Horst, I've been doing remote proctoring.
Yeah. Nowadays, it's much safer to go virtual now.
Yeah, and it works equally well, Horst.
What kind of system are you using?
So I've tried 5 of them.
Yeah.
The Proximi, the Stores, the Medinbox, the Avail, and one homemade.
Which one is the best?
You know, they all work. It's
Yeah.
like buying a car.
Okay.
You know, you like more one or the other, but they all drive.
Yeah, okay.
And what they do direct fitting of the fluoro image and the echo image into the transmission. So it's very high definition.
I've used it as well. So it's actually pretty good, right?
What system do you use?
I think they use the proximity. Proximity?
Proximi.
Yeah. And they could not, in the lab I was working, they could not connect to the fluoro, but I understand the principle and the concept. So it's,
okay.
Yeah, it's interesting. Yeah. But I mean, I think it's still a difference between being physically there and sometimes the camera is not focused. And so it's...
I had to say, I feel it is as good as being there.
Yeah.
And it allows someone like you and I, you can always spend an hour with someone anywhere in the world remotely.
Yeah.
And then we have the headphones, so I can hear perfectly.
Mm-hmm.
I have the high definition fluoro, echo. I see hemodynamics.
Yeah.
There's a camera on their hands.
Yeah.
And my communication with them is so direct. It's almost better than being in the lab.
Yeah.
Only thing I miss is the dinner the night before.
Yeah.
But we talk about the case beforehand. Yeah.
We should talk about this.
There was a meeting last week in Côte d'Ivoire. It's a digital meeting, and what the company that was organizing the meeting, what they have done, they actually distributed the lunch meal to the house of each participant, and it's packed in a very safe package. And that was a way of, sharing the same meal, but everyone is at home. How about that?
But Habib, this is outdated. This is outdated.
A good idea.
No, it's outdated. It should be possible to provide the visual experience of a lunch online, and also the smell and everything should be done kind of on.
But you know, Horst, for someone like you, myself, and many others to travel all over the world, spend 2 days to go do one case, this way you can, in between your normal cases in your own city, you can do this remote proctoring. You can be in all 5 continents the same day.
Yeah, I know. Yeah. So the virus had some positive side effects, right?
Oh, yeah.
I think we can start our session.
Okay.
35 past 11.
Oh, just to let you know, Habib knows this. I have to go for remote proctoring after my talk. So sorry for that. So I will just follow the discussion and then I have to go. Okay.
Okay.
We should have moved to the last position, last talk. Then we have.
No, the patient is already on the table, so I have to not change. Sorry for that.
Go ahead, Aisha.
Okay. So good morning, everybody, dear friends and colleagues. On behalf of the Moroccan Society of Cardiology, it's my great pleasure to introduce the joint session between the Moroccan Society of Cardiology and PAFCIC. I would like to thank Professor H.Gamra, who initiated this session. Actually, we were supposed to train our 2 congresses this year, but unfortunately, our project could not succeed due to the COVID-19 pandemic. Nevertheless, we insisted on organizing this joint session while waiting for the sanitary condition to improve so that we could all meet face-to-face. In this Congress, different themes in cardiology will be debated by renowned experts. So I would also like to thank them all for having accepted our invitation. Without further ado, I will give the floor to Professor H.Gamra, who will introduce and moderate the sessions. And thank you very much.
Thank you very much, Aisha. It is my really privilege and pleasure to co-chair this session with eminent cardiologists from Morocco that are very famous in North Africa. And I will start by Dr. ASA Chaara, who is just a pioneer of interventional cardiology in Morocco, but also in North Africa, very well known. Also, Dr. Samir Ztot, who is also pioneer in interventional cardiology, a real expert in many areas, and he's the former president of the Moroccan Society of Cardiology, and Dr. Nesma Bendagha, who is the rising star of interventional cardiology in our region. I have just would like to thank actually all the board of the Moroccan Society of Cardiology for giving us this privilege, and particularly Aisha, who's the president of this society, and who has really contributed in making everything possible to have this session ready to be done. I just would like to mention that actually we're having a very exciting program with a mixture of hot topics on interventional cardiology, and that will be presented by leaders on the areas. And I would like to start by Professor Horst Sievert. Horst, he doesn't need any introduction. He's a very big authority on interventional cardiology. As I always would like to present him, he's an expert in everything. And one of his areas of expertise is percutaneous closure of paravalvular leak, and he will be the presenter of this talk. So Horst, the floor is yours.
Thank you very much for this introduction. Actually, an expert in everything means I have no idea of anything. But let me share my screen here. So this is about paravalvular leak closure. And when I saw the title, I thought the best thing is to present a case which basically guides you through the steps of the procedure and also highlights the problems we are encountering with this procedure. May I ask who of the faculty has experience with paravalvular leak closure? Habib, have you done paravalvular leak closure? Gus?
Yes,
not by myself. Not by myself.
Okay, so it doesn't matter. I will ask you some questions in between, because basically this is about general interventional cardiology. So all the difficulties here can arise with several other procedures as well. So this is the case history. It's a 69-year-old male patient. He had mitral valve replacement. Let me move this to the side. In 2009, a paravalvular leak was diagnosed immediately after valve replacement, so during the hospital stay of the surgery. Then he's suffering from increasing pulmonary hypertension, and shortness of breath becomes more severe over time. And here you can see the leak in 3D echo. It's measured 15 by 10 millimeter, which is actually pretty big hole for paravalvular leak. And the strategy for mitral is, my preferred strategy is to come from the femoral artery and then go to the left ventricle and then try retrograde probing of the leak from the left ventricle to the left atrium, and then also retrograde device implantation. And with this technique, I do not really need, as you understand, I do not really need transseptal puncture. So you can see, this is the valve, you see the left atrium, you see the wire is across the leak. This was a Terumo angled wire, 035, and I used a JR4 to cross that leak. And then there was problem number 1. Actually, I had 8 or 9 problems in this case here. So this is problem number 1. And do you see what that problem is? You see it clearly. It's ventricular tachycardia. And this was caused due to the mechanical irritation by wires and catheters, obviously. So this was problem number 1. And obviously this can be solved by changing the position of the wire, and then this problem was easy to solve. Then we had problem number 2, and that was friction. And that is something you very often encounter when you try to close paravalvular leaks, not only in the mitral position, but also in the aortic position. And that was that advancement of a long sheath through the leak was impossible due to friction. That was the calcium in the annulus, it's the structure of the valve. So it's a problem which occurs very often. So what do you do? When the wire is across, you cannot advance a catheter. What are the options you are thinking about? Gus, what would you do?
Try
yeah.
Try a different, like a guiding catheter over the wire, or a diagnostic catheter instead of the sheath.
Yeah, good point. So I started with JR4, but I can go for other catheters, and one catheter I like for that is the glide cath from Terumo, which is a hydrophilic surface.
Right.
So that's an option. A sheath, you can try different wires. So I tried all this, stiffer wire, softer wire, guiding catheter, hydrophilic sheath, and I failed with all these techniques. Any other idea?
So try a different crossing point.
Yeah, that's a good point. But this was just one big hole. So actually there's it's an important point here. So sometimes you have sutures going across these leaks, and then you can just go to one of the other spaces there. But that's something which you cannot really see. It's just you can try, right? So what I did, I was able to advance. Snare, that's a good option. Yeah, snaring it. Then I would need the Transseptal Puncture, of course. But I wanted to avoid because of, well, it's easier to do it directly from the arterial side. So, but I was able to advance a Swan-Ganz catheter into the left atrium, and then I inflated it there. And the Swan-Ganz was in a sheath, and then I could advance the sheath into the left atrium by pulling and pushing. And I will show you in the next
Great
slide.
idea.
Sorry?
Great idea.
Yeah. So what you can see this here, the concept. So you are across the defect, which is, as I mentioned, a lot of friction due to the annulus and due to the mechanical structure of the valve. So then just advance. So this is the problem, what happens. The hole is a big hole. It's 5 by 7 or millimeters or something like that. But what happens is that any catheter or sheath gets stuck here at one of the structures of the valve or here at the calcium. So it's not really the diameter which is the problem, but it's the friction. So then you have the Swan-Ganz on the other side, and then you pull the Swan-Ganz back into the hole, and then you can advance the sheath using the balloon of the Swan-Ganz as a kind of a guide. And this technique is actually, as I mentioned earlier, it's not only for paravalvular closure. We use this technique also in other situations where it sometimes helps. For example, when you enter a vessel and you have friction there, then you can use this technique as well. Also using other balloons, PTA balloons, and so on. So then we had problem number 3, and that was air embolism. And that is something which always can happen when you have a sheath in a low pressure area like the left atrium. So you have to be aware of that, but you are using big sheath. This was a 7 or 8 French sheath. So air occurred, and you see this here on the T. I think it's a still frame. And what happened then was ST elevation and symptoms of cerebral ischemia. And this is typical for air because it goes everywhere, of course. And the question, again, this is a general problem which can occur in many other procedures like ASD or PFO closure. So what are you doing when you have that? Or if
so you give 100% oxygen through a mask.
Good point.
Because the bubbles are 80% nitrogen.
Mm-hmm.
So you give 100% oxygen, the nitrogen dissolves quickly and the bubbles disappear.
Mm-hmm. Good idea. Anything else in addition to that? That's something we certainly have done, but anything in addition to that? I mean, there's no good options. Yeah.
You give flood, you just give flood to the patient, very high volume, can increase blood pressure.
Yeah, fluid is good, yeah. Mm-hmm. But I mean, the air is already in. So, I mean, it's a good point to make sure that the patient is very hydrated before you do anything in the low pressure system of the circulation, but the air is already in. So I think one problem when air goes to the capillaries is that then in addition to the air, clots form. So I always give some heparin or 2B3A or something like that. So in this patient, there was spontaneous improvement after just waiting a couple of minutes. But if that does not happen, then I give heparin and 2B3A and so on. And I hope that I can prevent the formation of additional clots in addition to the air, because the air by itself, this will disappear after a short time anyway. So then we moved on and used there are different types of occluders we use for paravalvular closure, and one of them is the Amplatzer PDA occluder. And this is a 12/10 millimeter Amplatzer PDA. And you can see it here. This is the tip of the device. You can see how it is inserted there. This was a 7 French Cook shuttle sheath. And you can see the disc is exposed in the left atrium. It's very close to the valve, as you see, of course. You see the on TE. This helps very much to see whether we have to pull a little bit more or not. And this is opening of the proximal part, which is in the LV. And this is the advantage of the PDA occluder. It has short rims, so you have some risk of impinging the leaflets of the valve, but it's low because you have a small disc on both sides, actually. So is the position okay? Should we release it here? What do you think?
I'm not sure, but it seems okay.
Yeah, seems okay. And this is problem number 4, which does not really need an explanation. You see what happens?
Yeah.
The device embolized and is now floating around in the left atrium. So what to do now?
Go get it.
Yeah. You see it again. This is it's like a fly, right? Flying around in the left atrium.
Wow.
So how to get it? By surgery or what?
Snare it.
Snare it.
Oh, the snare.
Yes, so we did the Transseptal puncture here, of course. And what is important when I have that situation, I mean, I don't have hundreds of cases like that, but I had a couple of cases similar to that. I use a big sheath in the vein. I used, in this case, an 18 French sheath, and then 8 French transseptal sheath inside of that 18 French sheath. And you will see later on why that is important. So this is the Transseptal puncture. And this is now fishing, and I used a big snare. It's a German company, Osipka, but you can use any other snare. It has to be a big one because otherwise it's even more difficult to fish these things.
Is that just one loop, or is that the triple loop?
This one has just one, but it's
just one loop.
Triple. There are also snares available with multiple snares. Right. That would even be better, but they are smaller. So this is the disadvantage of them. So you just have to capture it in the right moment. And here it is. So I could not sinner the capturing or the fishing, but now you see it's connected to the snare here. And now I'm putting it back into the sheath. But this is now problem number 5. It was not possible to pull it back. And do you see why it was not possible?
Yeah, because that 18 French sheath is canted.
This is not an 18 French, it's a smaller one. It's a
that's the 8. Okay.
Yeah, 8, yeah. It's canted. You see here on the right side, you see, I already tried it here, and then you see that the distal end of the sheath is kind of inverted. So that prevents me from pulling it back. So what to do now?
You pull it back at the tip of the sheath and pull the whole thing back to the 18 French.
Quite brutal, isn't it? So I just, that's what I did. I just pulled stronger so that I could pull it through the septum. And then I was able to pull it down. And here it comes into play why it's important to have a bigger sheath in the groin, because now I can just pull it out of the sheath. Otherwise, I would have to pull it through the skin, and that's also not a nice procedure. And it actually, you may lose the device in this situation because the subcutaneous tissue and the vessel of the vein may be stronger than the interactive septum. So I was able to pull it through the 18 French teeth outside. So what now?
It's a bigger device.
Yeah, so bigger device, but I also thought about the different axes in this case. I already have the hole in the interactive septum, so I was able to recross that hole, which was created by the prior transseptal puncture and the removal of the device. And now I used an angled Terumo guide wire, JR4 catheter. Crossing in this area here of the mitral valve is pretty easy. It's much more difficult here on the side, but crossing from here, especially when it's such a big defect, is not difficult. And then I changed for an Amplatzer extra stiff, which was placed into the outer just to give me a more solid rail. And then I introduced a delivery system for a VSD occluder. So I wanted to have a device which has a bigger rim than the PDA. So that's why I switched to the VSD occluder. You see the distal disc of the occluder in the left ventricle. So I pulled it back. And then I did a tuck test, what I always do. So I push and pull to make sure that it does not embolize, as happened just before. This is a 12mm Amplatzer VSD occluder. And then checking the position and the valve leaflet interference. So what do you see here?
Is that a lot of thrombus?
No.
Oh.
Actually, everything is looking good. So you see the leaflets are moving. You see the correct position of the device. So that's fine.
The question is to see on Doppler if there is flow on the sides of the device. See if you need to put a second device before you release this one.
That's a good idea, but actually with these type of occluders, the VSD and the PDA, you always see flow through the device because they
through the device, right? The question is the sides of the device.
Good point. So I think we did this, but I did not record this, so that was obviously okay because otherwise I wouldn't have seen it here. But then what's very important in mechanical valves is to make sure that the leaflets are moving freely because you may interfere with the leaflets and then you have a problem. So you see, I do this under fluoro and echo as well. You can clearly see that the leaflets are moving freely, so that's fine. But then we have problem number 6. And now you can see on echo here, the leaflet is, this leaflet got stuck here. This one is moving, but now this one got stuck. Can you see that?
Yeah.
Yeah. So that's something you should not leave. So it was still connected, fortunately. So I just pulled it a little bit stronger into the defect and redeployed it. And this is now, again, a tuck test to confirm the position of the device and stability. And then the device is released. And you see the leaflets are moving freely, so that looks good. Problem number 7 actually came on the next day on the regular ward. The patient suddenly collapsed. CPR was performed and successful, and EKG showed sinus tachycardia. And the question is, what happened? What is that? Any ideas? You have that information to make a diagnosis from the prior events.
Embolized again?
It could have been embolized, yeah, but I mean, what?
That should make him collapse, yeah.
Yeah, I mean, patient should not collapse. Actually,
pericardial effusion.
Pericardial effusion, yeah, but that would be unexpected. The event, what happened here was actually not expected, but kind of typical complication.
We can do echocardiography, and after we can do fluoroscopy to see.
Yeah, yeah.
And diffusion.
So what happened, it was pulmonary embolism, and that was, here you see this on this end here. And this was due to the big sheath in the groin. And this is obviously something which can cause a deep vein thrombosis and then consequently pulmonary embolism. And so PA pressure was 60/30. Lysis was contraindicated due to the recent arterial puncture. Patient was stable after the initial collapse, so we gave him heparin only, and patient was doing fine. But then we had problem number 8, and that was some neurological dysfunction, which was persisting at day 2. CT showed no ischemic infarction. Symptoms improved over the next few days, and fortunately had full recovery before discharge. So the outcome, I'm running out of time here. So the outcome, marked clinical improvement, no permanent neurological dysfunction, no other complications. And also we did not have any problems in the next 8 patients, just to ensure you that it's not always like dangerous like this one here. Thank you very much for your attention.
Very nice case.
Thank you. Yeah, thank
Very
you very much.
instructive. I'm glad the
Thank you very
patient was in
much.
your hands.
I'm not sure, because I caused
Yes.
complications.
You have the expertise to come out of all 9 complications.
Any questions or comments?
Horst,
Yeah.
what was the length of that procedure?
I don't recall, but maybe 20 minutes, something like that.
The whole procedure?
I don't remember. I don't know. I don't know. Just
Okay. Yeah. So I think one of the problems with such a procedure, when you do embark in the procedure, you don't know when you finish. It's very rarely very straightforward thing. I mean, most of the time you have issues like what you have described, but it could be others. But you know, I was with Faralley League once in South Africa for closure of percutaneous closure of a valve like this, and the procedure has lasted, I think, 3 or 4 hours. So it's sometimes it's very you know, bumpy procedure, very complex.
Yeah, but what is important, I think it's one of the most difficult procedures we do in the cath lab. But on the other side, it's not, despite all these complications you have seen, it's usually not a dangerous situation. There are technical difficulties and problems, but overall the results are showing that this procedure is very safe. So I don't recall one single patient who was sent to emergency surgery or something like that. It's really
definitely safer than repeat surgery.
Exactly, which has a very high mortality. So in these days now, our approach is in all patients with paravalvular leak, try transcatheter closure first. And only if that does not work or is not feasible, then we switch to surgery. Even after the first paravalvular leak, we don't wait for the second redo operation. We always try catheter treatment first.
Horst, do you have a practical recommendation on how to launch a program of percutaneous occlusion in one cath lab, in our environment, for example? I mean,
I don't have
recommendations.
Yeah, I mean, you should. It's an important point. You should have different devices available and multiple catheters, devices for closure, sheath. So you need a huge armamentarium in order to be prepared for all these difficulties, because it would be kind of a disaster if you have crossed a leak, which sometimes takes an hour, and then you find out that you don't have a proper size of the device to use. So it's important to have a big armamentarium on devices, wires, and catheters. So that's one point. I mean, all the other things, as I said, it's not something which is really specific. It's not like embolectomy from the brain. All these techniques are conventional interventional techniques, so there's nothing special. Maybe you should organize a course or something like that for this.
You know, you inspire me to think that one way to do it, Habib, would be to set up a transmission system like this Proximi.
Yeah.
So you could have people like Horst to assist you remotely on the cases. And then he can do that repeatedly until you are perfectly self-sufficient Or even after you are self-sufficient, you have a especially difficult case, you call for a remote proctor to be with you in the lab remotely. I think that's a lot of the future.
Exactly. All right, thank you very much, Horst, for this talk, and thank you once again for your support of PAFCIC. Just to remind everyone that Horst Sievert and Augusto Pichard, by the way, they're very active co-directors of PAFCIC, and their support over the years of this initiative has been absolutely instrumental for keeping PAFCIC at the level that he has now. Thank you very much, Horst.
Thank you. Goodbye.
Now I will ask Nisma to present the next speaker. Nisma, are you connected?
Yes, I'm here. Hello.
Go ahead.
It's my pleasure to introduce my colleague, Professor Samir Ztot, interventional cardiologist in the private sector and the late president of Moroccan Society of Cardiology. Samir, go ahead.
Thank you, Nesma. Hello, everyone. It's always a pleasure to talk to you. First of all, I would like to thank the Moroccan Society of Cardiology and the PAFCIC, headed by Professor Aouad and Professor H.Gamra for their invitation for this session. It's always very difficult, and it's an honor to speak between Horst Sievert and Professor Sievert and Professor Augusto Pichard, but I try to do my best. My topics today is the management of percutaneous intervention in high bleeding risk. As you know, coronary angioplasty in high bleeding risk patient remains very, very complicated because the fragile balance between bleeding and thrombosis. And this balance is very high when there is atrial fibrillation and ischemic disease that constitute dangerous combination. The use of the best use of dual or triple antithrombotic therapy is one of my focus in this presentation, and the other is the guideline and the future perspective in this presentation. We begin by a clinical case. It's an 83-year-old woman who suffered chronic HTA with the history of external hemorrhoids. She had a paroxystic atrial fibrillation since 2010 and the new oral anticoagulant. She had on September 2019 palpitation increases that revealed NSTEMI troponin positive, and the echo revealed the left atrium slightly dilated with good ejection fraction. The EKG revealed the sinus rhythm with the bifascicular block, and the patient was treated by clopidogrel, rivaroxaban, and aspirin. She had a radial coronarography with the 2 vessel lesion, and we did angioplasty with the 2 stent onyx on the LDA and the circ. This is the lesion of the LAD, proximal LAD. There is a lesion of the ostial circumflex. The right coronary was good. We do the angioplasty. You have the slide, please, Habib?
Yes, Samir, we see it very well.
Okay, we do the stent 2.526 onyx on the LAD. We do another stent on the proximal circ. And the final result seems good. And this patient have a favorable improvement of the angioplasty, and the discharge treatment was rivaroxaban, clopidogrel, and aspirin. But 1 week after, she had moderate rectorrhea, and we did electrocoagulation and switched to apixaban, stopped aspirin, and used dual therapy, apixaban twice and clopidogrel for 6 months. There was a favorable evolution with neither ischemic nor hemorrhagic event. This case is very important to balance between the ischemic and the thrombosis, the ischemic and bleeding risk, and during and after PCA, management of patients with atrial fibrillation must balance the risk of bleeding with the risk of thrombosis. And the risk of bleeding is very important when we do a PCA and in a person who had atrial fibrillation, like you see. Slide is very important to explain the 2 phases of acute coronary syndrome risk, and it shows the thrombosis, the thrombotic risk is more important in the first months than bleeding risk, and the bleeding risk is very important after 1 month. That's why the recommendation try to recommend hard treatment in the first months, and after we try to delay some treatment. And for this, the European Society of Cardiology use a risk score for guidance the duration of dual antiplatelet therapy, and the 2 score is the score precise depth in the moment of the angioplasty, or the score depth after 1 year after angioplasty. This slide we can download from internet this precise depth, and the items used was the hemoglobin, the calculation of the hemoglobin, the white blood count, the age, the creatinine clearance, if there is a prior bleeding, and when the score is more than 25, we use short depth, and when the score is inferior to 25, we use standard or long depth. For the depth score, after 1 year after the angioplasty, there's another item like smoking, diabetes, and it's important to mention the paclitaxel eluting stent, because it's not good for bleeding, or the stent diameter that is inferior to 3 millimeters. There's another score that is the academic research consortium on HBR that we use easily, and summarize the high bleeding risk patient on this slide, and we see that the age over than 75, We see prior bleeding. We see creatinine clearance. We see any stroke before, any liver disease, any use of non-steroid or steroid before angioplasty. And this patient who undergo to PCI and high bleeding risk are about 30% of our patients. And the major bleeding after PCI is multiplied by 4 short or long-term mortality. And the management of this patient remains controversial, and it's important to choose the type of the stent, BMS or DES, or the duration of the DAPT. How to reduce hemorrhagic complication? We must deal with the association of anticoagulant, duration of antiplatelet therapy, the type of stent, the use of PCI or cabbage, and the use of access, vascular access, radial is more interesting, and we must prevent gastrointestinal bleeding. On the time of the study on the type of the stent, we can tell that the LEADERS-3 study is the first randomized study to evaluate efficacy and security of short DAPT with polymer-free DES/BMS in 2004-66 high bleeding risk patient. And this study show and demonstrate superior clinical efficacy of DES versus BMS with 50% reduction with revascularization risk and superior security of DES with 29 MACEs reduction, including stent thrombosis. This is the graph that showed this leader study. There's another study with the Synergy and Rebel, compared Synergy and Rebel senior trial, and the MACE for 1 year, and the MACE was good for the Synergy, and the safety better for the Synergy slash Rebel BMS. The third study is Onyx-1 global study. It's the only DES versus DES trial in high bleeding risk patient with 1 month DAPT, and it's compare Resolute Onyx with Biofreedom. And we see that device success is more interesting by Resolute than Biofreedom, and the safety and DES was safe and effective in HBR patient with 1 month DAPT. The one clear US and Japan is the same study that the performance was very interesting, that Onyx study reinforced the safety and the security of this type of the stent. And now let's move to the recommendation and perspective in treatment on high bleeding risk patient. And we began by chronic coronary syndrome. And the recommendation of ESC in high bleeding patient was dual therapy for 1 month to 3 months, aspirin clopidogrel. The questions for the moment is, there is alternative. Can we safely withdraw aspirin when novel, more potent P2A12 inhibitor are used? And for discussion, multiple study like Stop DAPT use 1 month DAPT, and and compare group single antiplatelet and dual antiplatelet, and we see that the MACE is the same, and in bleeding is more important in 12 months than 1 month 1 month single app. Cardiology do the same with the Twilight trial that enrollment 3 months, and ticagrelor with aspirin for 15 months, and ticagrelor only. And we see that on the MACE it's the same, and in bleeding ticagrelor single is more efficient and more safety than ticagrelor aspirin. That's why the recommendation, European recommendation and American recommendation in high bleeding risk, 1 month for BMS, 3 months for DES, and the European the same, 3 months for DES and 1 month for BMS, with the relevant of B and C recommendation. What's about acute coronary syndrome? The ESC 2020 highlight on bleeding risk on very high risk that 1 month dual therapy aspirin clopidogrel and clopidogrel for long term, and in high risk aspirin clopidogrel 3 months and aspirin only for the long term. What about the non-STEMI? The non-STEMI in high bleeding risk, aspirin ticagrelor or clopidogrel aspirin for 6 months. And now what about atrial fibrillation, PCI, and high bleeding risk? You know that 1 to 2 million persons can have revascularization and have atrial fibrillation and take oral anticoagulant. And there is a huge difference between person who have atrial fibrillation and no atrial fibrillation in the mortality when we want to do a PCI. The classical indication for anticoagulation was paroxystic, persistent, or permanent AF with such VASC score more than 2, mechanic protective valve, deep venous thrombosis, and pulmonary embolism. And this slide shows the network of 4 antithrombotic treatment regimens, and the first regimen study was worst, and after Pioneer with rivaroxaban, Retrieval with dabigatran, Augustus with apixaban, and the last test was Entrust. The worst study demonstrated the dual therapy with vitamin K plus clopidogrel reduced bleeding risk versus triple therapy, addition of aspirin, without compromising efficacy, like we see in this graph. The MACE was good and the bleeding was less. Pioneer AF-PCI reduced composite endpoint bleeding event with rivaroxaban-based regimen versus VKA triple therapy. Retrieval significantly lower rate with lower rates bleeding with dabigatran dual therapy versus warfarin triple therapy. We see that all the studies go on ahead on the efficacy of dual therapy and the safety of dual therapy. And that's why the recommendation of European Society of Cardiology was in a high bleeding risk dual therapy clopidogrel oral anticoagulant for 12 months. The North American expert consensus recommends dual therapy as the default strategy for most patients, and for high bleeding risk, triple therapy, oral anticoagulant, and DAPT for 1 week, and after double therapy, OAC plus single antiplatelet for 6 months, and oral anticoagulant for 6 months. And the conclusion was that the development of new generation of DAS, like Onyx, like Biofreedom, allows us to deal with high bleeding risk. We must use always vascular access, and radial access is preferred. We must use gastrointestinal protection. Clopidogrel is more recommended in high bleed risk patient. And for the length, in chronic coronary syndrome, we do 1 to 3 months DAPT, then long-term single therapy. For the SCS in H.BR, we do 1 to 3 months DAPT for non-STEMI and 6 months DAPT for STEMI, then long-term single therapy. And when we have atrial fibrillation and PCI in H.BR, we use the new oral anticoagulation plus 1 antiplatelet for 6 months, then 1 new anticoagulant for long-term. Thank you for your attention.
Thank you very much.
Very nice talk.
Samir, for this great talk that give us some answers to several questions in a very tricky situation in clinical practice, which is the management of patients with high bleeding risk.
Can I make a comment?
Any question to Samir? Yeah, of course. Go ahead, yes.
So Samir, a wonderful summary of a very complicated subject.
Yes.
In my experience, what I've learned is, for the last few years, we never give triple anticoagulant, never.
Okay.
Now, in a high bleeding risk patient, if you do optimal PCI, you know that stent is perfectly expanded, it's a short stent, there are no other lesions. I only give 1 antiplatelet, not 2, just clopidogrel, and often for just 1 month. Now, if the angioplasty, you're not sure, was very calcified, you didn't have ultrasound to confirm there is a perfect result, then you're forced to consider maybe 3 months. But those two things. The final comment is that there's no reason to use BMS because of bleeding risk. All the new data shows that the new stents, the new DES, have the same or less bleeding risk than the BMSs because they have less thrombosis. So there's no reason to use BMS because of a bleeding risk. Today with the new DESs, they have less thrombosis than BMS. So the only reason to use BMS would be price. Yeah, would you agree with my comment, Samir? You are now the expert. You reviewed the subject.
I think for BMS, it's only price, and I think even in Morocco with the low person have lot of money, it's not a problem because there is no difference, large or huge difference between DS and BMS on the price.
Oh, good.
The second point, I'm very interesting that you tell that it's you use only one antiplatelet when the stenting is very good. It's
just Plavix.
Plavix, and for the atrial fibrillation, what?
Oh, then they need, yeah, either NOAC or Coumadin plus the Plavix for 1 month. Then they stay on the NOAC for the atrial fibrillation.
Okay, okay, okay.
So, Gus, would you prefer clopidogrel on ticagrelor, for example?
Clopidogrel instead of what?
Ticagrelor.
Also, ticagrelor for acute coronary syndromes, acute MI.
I mean, okay, you're looking for.
But for angina,
elevation.
There's no reason, right?
Okay. Now, my second question to you and to Samir, you have, do you have an antiplatelet regimen that is different from one patient to another based on the complexity of the anatomy? For example, in left main, it's a little bit different, or it should be different from just a simple proximal LAD. Bifurcation with 2 stents, it's different from, again, a proximal LAD. Do you have different regimens in these 2 category of patients?
So the way I look at it is lesion complexity. Left main is usually easy. It's a simple lesion. You put a big stent, 4 or 5 millimeters, with a nice big lumen fully expanded. Now let's say it was a calcified left main, and the stent was not well expanded, or sticking out in the aorta, or it's a bifurcation stent, as you say. When it's complex, there's more likelihood of thrombus developing in the stent. But a simple lesion at the ostium or the mid left main, that you put a beautiful stent there, or a simple lesion anywhere, LAD, circumrite, that helps you do less anticoagulant. Now, a very complex lesion, you do it guided by imaging, OCT, ultrasound, and you know you have a perfect result. That now becomes a simple stent, because the likelihood of thrombosis is very minimal. You know, fully expanded, no edge dissections, all of that. That's the way I look at it.
Professor Chaara and Nesma, do you have questions? Nesma? I have another question. I think we went over time, but I think it's a great opportunity to have your answers on this. You know, we have 2 trials. We have Onyx 1, we have Leaders 3, who have validated 2 stents. Do you think the finding of those 2 stents or 2 trials can be extrapolated to other stents? For example, can you do the same thing with Xience stent?
Yeah, we've been doing the same thing with Xience for 3, 4, 5 years. Xience well placed with optimal result. I only gave 1 month of dual antiplatelet for years now. I never had problems.
You should have published that, Gus. So it's very important.
Yeah.
All right. If you don't have any other question, I would ask Dr. Asad Chaara to present the next speaker.
I introduce Dr. August Pichard from Washington Hospital. He is the chief of interventional cardiology unit. He is a good friend of Morocco and Europe. He will take a talk about latest innovation and the new indication of TAVI.
Thank you very much, Dr. Chaara. Thank you, all of you, for inviting me to be with you. Indeed, I'm very fond of the Moroccan team and Habib's PAFCIC participants. So thank you again. I want to briefly talk about, let me see, can you see the slides?
Can you just
no,
share your
not
screen?
Yet.
Let me then go to share somewhere. Oh, display settings.
It's in the bottom.
Just open your presentation and click on share screen on the bottom.
Yeah, I'm looking for that. Screen. I'm going to end the show and then go back. Let me see.
Just return to Zoom. After opening the presentation, return to Zoom and click on the button on share screen. The green button.
Yeah, it's all big. Let me see. Let me go to Zoom. Here we go. Share screen. Okay.
We see it now.
Great. Thank you.
Perfect.
So this subject, of course, we could talk about it for 3 days. I'm going to make a summary. So the indications for TAVI in 2020. Can you hear me well, by the way?
If you can just
Yes, Gus, we hear you very well.
make it on full screen, if it's possible.
There?
Perfect.
Okay. So for patients with extreme risk at surgery, the randomized trials for SAPIEN and core valves show that TAVI was in SAPIEN better than medical therapy, of course, and in core valve was as good as SAPIEN. So the FDA approved it. For high risk, the randomized trial, and this is 5-year follow-up, showed that surgery and TAVI have equal results. And then the FDA approved it. For intermediate risk, same thing. 2-year result showed that TAVR was the same or better than surgery for SAPIEN and Evolut, and the FDA approved it. And for low risk, SAPIEN showed that TAVI was better than surgery, and Evolut was the same as surgery, and the FDA approved it. The hemodynamics of TAVI versus surgical aortic valve replacement also show that TAVR has better valve area than surgery and less gradient. So the first conclusion today is that randomized trials have effectively proven that percutaneous treatment is as effective and safe as surgery to treat severe aortic stenosis. And as you know, that's been a revolution in medicine. Now, what's happened with the access site for TAVI? 95% today is femoral access, as shown in this TVT registry. Transapical and transaortic are no longer recommended. Anytime you enter the chest, there are more complications. Transaxillary is rarely used and is shown to have more complications than femoral. Now, if none of these are available, you can do transcarotid or transcaval. Let me show you briefly what's happened in the United States. In America, the hospital and the doctor do not get paid unless you enter the case in the Society of Thoracic Surgery and Transvalvular Therapy registry. And thanks to that, we have very good database. So there are 688 sites in the US, mostly in both coasts, which is most people live. And what have we found? This is the volumes from 2012 to 2018. Of course, TAVR is gone up tremendously. And a simple aortic valve replacement, isolated in red, is similar, 29,000, 25,000. So it's come down a little bit. What's happened, according to the European publication, in the rest of the world? So Northern Africa, which is here, in this publication, it's less than 1 per million. Germany is the highest in the world. But wait, can you see my arrow?
Yes, yes,
Yes.
because we see it.
Oh, okay, great. Germany has the highest with more than 150 per million. And the rest of the world, you see, is distributed in different ways. There are big parts of the world where TAVI is still not performed. What's happened to mortality? In hospital mortality, at the beginning was 6%, now it's about 1%. So 1% mortality in the hospital is less than surgery. Now, according to risk category, for high-risk patients, intermediate and low risk, the in-hospital mortality 2% and about 1% in blue. So that's very reasonable and very acceptable for what is usually older patients. Now, stroke rate has not changed much from 2012 to 2019. It's about 2–3%. In the hospital, 1.5 to 2%, but at 30-day, 2 or 3%. So this is something to change, and we're hoping for good cerebral protection. We still do not have a perfect one. New pacemaker. In-hospital pacemaker and 30-day, as you see, have oscillated about 10–12%. It's less of balloon expandable, it's more with self-expanding. And I'm going to talk about what we've done recently to decrease this rate of pacemakers. It's not good for the patient. The LV function does not recover as well. It's very expensive. Sometimes there are problems. The leads get infected. There's no good capture. The patient has to come for pacemaker checks. So we want to do TAVI ideally without pacemaker. Length of stay in the hospital used to be about a week. Now is 1 to 2 days. Bleeding. Bleeding is a problem. And the reason is we use a huge catheter in the femoral artery. So it's decreased from 6 or 7% to 2 or 3%, but still a problem. Now this is important. How many patients with TAVI get PCI? In the trials, about 12%. In the registries, about 25%. So you can remember, between 10% and a quarter of patients will need PCI. Frequently, they are complex lesions because they are older people. BC type lesions, calcified lesions. The success rate is high. There's low rate of lesion failure, thrombosis 0.4, restenosis 2.3. But also we've learned that incomplete revascularization pre-TAVI has increased risk. Incomplete and complete. Why is this important to remember? Because we need to consider coronary access as we choose the device for the TAVI. So that's a brief summary of what's happened with TAVR in the world now. Let me talk about new indications for TAVR. Asymptomatic severe stenosis. These are 2 trials that have shown that in asymptomatic patients, if you do early surgery, the outcome is much better than if we treat them medically, waiting for symptoms. That was by Dr. Kang, published in the New England Journal. And another one coming from Korea showed that if you do a aortic valve replacement in an asymptomatic patient with severe stenosis, the outcome at 10 years is much better, less than half the mortality than if you watch them conservatively. So how do we approach asymptomatic aortic stenosis now? We need to remember that many patients think that they are asymptomatic because they don't run, they don't ride a bike, they don't go fast upstairs. So they say, no, I feel fine. So today the guideline is if the patient has severe stenosis and says no symptoms, you, the cardiologist, must do a stress test, which used to be contraindicated when I went to medical school. Now it's indicated to confirm asymptomatic status. And if the stress test shows arrhythmia, shortness of breath, then surgical or percutaneous replacement is indicated. There are 5 trials now evaluating the treatment of asymptomatic severe AS with TAVI. So we should know in the next couple of years what these randomized trials are showing. Another question has come up. Moderate aortic stenosis. Should we consider TAVI? And what's moderate aortic stenosis? Gradient less than 40, peak velocity less than 4, valve area more than 1. The traditional teaching is you don't touch these patients until they become severe. But let's look at the data. These are 240,000 echoes in Australia. 19,000 of them had aortic stenosis. So this is a survival at 16 years. Patients with no aortic stenosis, mild AS, moderate, and severe. Look how moderate has a same survival as severe aortic stenosis. Even mild aortic stenosis has a compromised survival. That's a big surprise. And Dr. Amanullah showed at TCT this week something very important. For patients with moderate aortic stenosis, there are different types. Stage 0, he calls it, with no cardiac damage. And stage 1, 2, 3, 4 have LV dilatation or hypertrophy, left atrial dilatation, mitral regurgitation, pulmonary hypertension, tricuspid regurgitation, or RV dilatation. So the approach should depend on how involved the moderate stenosis has affected the rest of the heart. And he showed this beautiful diagram, survival of 5 years. Patient with stage 0, 1, 2, 3, 4. So moderate aortic stenosis with involvement of the left ventricle, left atrium, right side, has very high mortality. 2 trials are evaluating TAVI, randomized trials. The UNLOAD trial, which I understand is fully enrolled by now, waiting for results, and the EXPAND trial for Medtronic. So we're going to have randomized data, but based on what I show you here, I suspect that we may have to consider TAVI also in moderate aortic stenosis, especially if they have high stage. Now, valve-in-valve for degenerative bioprosthetic surgical valves. And this is a diagram from the European Heart Journal. 7,000 patients, they propensity matched 2,100 for redo surgery versus TAVI. And what did they show? That TAVI had less mortality, half the mortality of surgery, had less morbidity, half the morbidity of surgery, and less bleeding, almost half the bleeding that surgery. So valve-in-valve with TAVI is much better than redo surgery, according to this big study. And what's the long-term outcome of valve-in-valve? These are 1,000 patients followed for 8 years. If they had pre-existing patient prosthesis mismatch, that means the valve was too small originally, the surgical valve for that patient. If you do valve-in-valve, the prognosis would be worse than if there was no pre-existing PPM. Now, in this study of 1,000 patients, sapien valve had more reintervention than Medtronic. But you see, it's very little at 8 years, 6% and 2%. So reintervention is not a problem and the results are good. What are the pending issues for TAVI? The need for pacemaker, I mentioned, is 10 to 30%. Nowadays, we've learned that with the CASP overlap view, where you overlap the right and the left CASP, and you implant the valve much higher, the pacemaker rate published has been 2, 3, 4, 5%. Much less. So we are all changing to implant the valve in the 2 CASP view with better results. Stroke, which is 1 or 2%, we need a protection device that will totally protect the brain. We don't have that yet. We need to eliminate vascular complications. We don't know what to do for anticoagulation. There's valve thrombosis or valve leaflet thickening, which appears not to be serious, but we don't know much yet about it. We don't know whether a patient should be on 1 antiplatelet, 2 antiplatelets. In most big centers, these patients only get aspirin, no longer Plavix. And coronary access, as I explained earlier, is important after TAVI for many patients. So we need to plan on it. And this is a separate lecture by itself. I won't have a chance to talk about it. How do I see the future? There are new valves coming up all the time. And in this lecture, I'm not talking of the valves available. Each one of you in your own site will have access to certain valves. My advice is use the one that they give you and use it all the time and develop experience with it. But the newer valve has better performance, lower price. The group in South Africa, in Cape Town, has developed the African valve, which they told me when I saw it for TAVI was going to cost $1,000. And I know they've implanted a few already, but I don't know what the price is going to be, but you need to be in touch with them. It's a Barnard Institute of Research in Cape Town. This new technology for synthetic leaflets, which are not going to develop thickening, which may last longer, which may not need anticoagulation. I talked about total cerebral protection. There's all kinds of computer modeling and 3D printing. So you can really choose the valve size and the device choice scientifically, not just by guessing. Remote monitoring is also an important field. Implantable, but better cutaneous, or even with a watch, to use before and after the TAVI. Before, to determine which patient is having syncope from AV block as opposed to aortic stenosis, and so getting a pacemaker beforehand. And after TAVI, because it's a small percent of patients that will go to have AV block after they leave the hospital, and a few of them will die from that. And length of stay, as you know, is going to 1 day for many patients as the procedure gets simpler. So in conclusion, TAVI is now the gold standard to treat severe aortic stenosis. It's the optimal choice for degenerative bioprosthetic valves, valve-in-valve. Expanded indications are being evaluated, asymptomatic and moderate. Experienced operators are required. It's another place where remote proctoring may be of great value. Current results show high success rate and low mortality morbidity. Improved devices continue to be developed, and long-term follow-up, more than 10 years, is not yet available. Thank you very much.
Thank you very much,
That's it.
Dr. Pichard. I start because I have two questions to you.
Okay.
The first question is, what do you think about the TAVI as an indication of important aortic insufficiency associated with mild aortic stenosis with calcified valve?
So we don't have yet a device that's perfect for that. The Jena valve is perfect for that, but it's not widely available. It doesn't exist in America, it exists in Europe. The current valves for aortic stenosis have been used for the aortic insufficiency, and it does work, especially if there is calcium. The results are very good. It requires a lot of expertise. Often it requires two valves to secure it in the annulus. So you put one valve on top of the other.
And the second question is about bicuspid aortic valve. What kind of prosthesis you recommend? Sapien, Evolute, or Portico, the last prosthetic?
So my bias was that bicuspid would not be for TAVI because it has so much calcium and they're young patients and they have aortopathy. But the data has shown that it works very well. It works the same as tricuspid. And you follow some strategies. You can use any valve. You can use self-expanding or balloon expandable. The data that we have only goes for 2 years. So at 2 years, the results are the same as a tri-leaflet valves. My advice is for the young patient with severely calcified leaflets, with big chunks of calcium, I still think that surgery is better. Because when there's too much calcium, the TAVI will not expand well, will have paravalvular leak, and there's a risk of annular rupture if you really try to expand it well. For the usual bicuspid, or what they call senile bicuspid, is just tri-leaflet with fusion of 2 leaflets. Then the bicuspid works fine. The TAVI works fine.
Other question?
I have a question.
Panel?
Another question.
Other question for panel? Dr.
Okay. Dear, is there a direct cause and effect relationship between moderate aortic stenosis and ventricular dilation? So is moderate aortic stenosis responsible of the evolution and the prognosis?
So yes, what happens is that in some patients with moderate aortic stenosis, low gradient, the ventricle is still struggling to generate cardiac output, and it does develop hypertrophy, does develop dilatation. Why some patients do and some don't, we don't know. And it's maybe genetic, and maybe it's a type of moderate stenosis, we don't know that. But it's interesting that I show you that on the different stages of moderate aortic stenosis, patients are different.
Thank you.
Thank you for the question.
Yeah, I guess I have a question to you regarding the valve generation at long term. You know, that's maybe a concern of the early generation of those. Anything that is being done now to try to make that, to prevent that, or to have it happen very late?
So duration of the valves. So far, we have proof that at 5 years, it is in fact better than surgery. The valve area is better, the gradient is lower, and there's no more degeneration for TAVI than for surgery. In fact, one paper last month showed more degeneration for surgical valves than for TAVI when evaluated with the same protocol, the same echoes. So we don't know between 5 and 10 years. The hope is that it's because it's the same leaflet manufacturing as a surgical valve, and because the hemodynamics are better, we hope that it's going to function, to last equally well. But we have no proof at 10 years yet. It should come soon. We started doing TAVI in 2007 on the randomized trials. So it's been 13 years. And those patients originally were all such extreme risk that most of them have died. But we will have intermediate and low risk follow-up in the next 5 years, I hope. Let me say a word about leaflet thrombosis, leaflet thickening. There was big concern because, as you know, on CT, it was found that some valves had, the leaflets were thickened and were not moving well. And we found out that with coumadin, with normal anticoagulants, that would clear. But later we have found out two important factors. The leaflet thickening occurs with surgical valves and with TAVI, a little more with TAVI. This leaflet thickening appears 1 month, disappears the next month, appears again, never comes back, or comes back, with anticoagulants or without anticoagulants. So we have no idea why it occurs or how to treat it. More important, the data from the Portico randomized trial that had CT to evaluate leaflet thickening showed that at 2 years, patients with leaflet thickening had no more gradient, no more strokes, no more problems. In fact, they had less stroke than the ones without leaflet thickening. So no clinical consequence. We don't know that phenomenon, why it happens, and we don't know how to prevent it.
Another question, Gus. I want to know the strategy when that you do when there is a coronary lesion and TAVI. You do all in the same or before, or what's your strategy?
So two things. Usually they are complex lesions, so we like to do them a month before, because for these patients tend to be older and sick, heart failure. Most of them have poor renal function. So, and PCI, you never know when it's going to be 2 minutes or 2 hours. So as a precaution, these older patients, we tend to do it earlier.
Yes.
Now, if it is truly a very simple lesion, very focal, with no evidence of calcium on fluoroscopy at least, then we do it at the same time to save the patient one admission to the hospital, and we minimize the contrast.
Okay.
Thank you, Dr. Pichard. I give the talk to Dr. Ztot to introduce our friend, Dr. Gamra, and to moderate the session.
Okay.
Thank you very much.
Thank you, Dr. Chaara. Donc, I introduce our friend H.Gamra. It's one of the leaders of cardiology, interventional cardiology in Africa, and he's the president of PAFCIC, and the co-founder of the PAFCIC, and he's head of the Department of University of Monastir and Tunisia. And his talk today is the PCA for CTO, current indication and technique. You have the floor, Habib.
Thank you very much, Samir. It's again my pleasure to be with you today, and many thanks to the board of the Moroccan Society of Cardiology, who has accepted actually to have this joint session with the annual meeting of the Moroccan Society of Cardiology. You know that the PCI for CTO is a very rapidly evolving area thanks to the development of techniques and equipment, as well to the increased training of the person. I have no disclosure for this talk. Now, there's no doubt that PCI for CTO is one of the most challenging procedures in the cath lab nowadays. It is technically difficult to treat. This is procedure time intensive. Most of the time it's complex. It requires significant contrast load, and it is associated with a certain rate of complications. Now, as to the success rate, historically it was about 50% when we started doing this procedure many years ago. But now this success rate has dramatically increased to more than 90%. Just to show you the rate of success in this clinical and very large registries, the Progress CTO, which is an American registry, 88%, the Open CTO, which is an international registry but initiated in the USA, 86%, and the experience of European colleagues with the EuroCTO Club, the success rate is 88%. Does that mean that we should give into temptation and attempt all CTOs because of this high success rate? This is a question asked by Galassi in one of his editorials. And the question, of course, not at all. You should all the time try to go through a rational analysis, taking into account the clinical, anatomical factors, but also another important parameter, which is the operator's experience. Now, in the same time, there is no doubt that CTO is associated with adverse outcome. And this is one of the big registries you certainly remember of the SCAR Swedish registry that has included more than 200,000 patients with PCI. And among that large registry, there was more than 14,000 patients with CTO. They have actually looked at the outcome of these patients over the years after 6 years of follow-up. And it is very clearly shown in this graph that CTO was associated with increased mortality. So it's not benign to have a CTO in your coronaries. And by the way, the conclusion of that trial was that there is an increased mortality in patients with CTO, and that association was most prominent, and this is really important, in younger patients and those with acute coronary syndrome. Another trial, this is a Spanish trial that has looked at the impact of having a CTO on the recurrence of ventricular arrhythmia in ischemic secondary prevention implantable ICD in patients who had an ICD, and they have looked whether patients with CTO have a comparable outcome to those who didn't have a CTO. And this is the finding of the study. They have looked at the freedom from appropriate ICD therapy according to the presence of CTO, and they concluded to find a higher risk of ventricular arrhythmia recurrence and mortality after 5 years compared to patients who had CTO in green and those who didn't have a CTO in blue. So CTO is not a benign thing, but that does not imply you should proceed with PCI in every patient with CTO. In practice, there are questions that every operator should ask before embarking in such a complex procedure. And the first question is there an appropriate indication for doing the procedure? There is a large registry, Chinese one, that was conducted in Fuwai Hospital. I don't know if you have heard about this hospital. This is the hospital that has the world's largest cardiovascular center with more than 1,200 beds and 13 cath labs. In that registry, they had more than 42,000 patients included, and among them, they have identified something like 2,600 patients with CTO. And what they have looked registry, they looked at the 5-year incidence of a composite endpoint of all-cause death, all MI, and or hospitalization due to heart failure, which is quite interesting. They have looked at the appropriateness of indications. So they have actually looked on the indication, it was appropriate or inappropriate, and compared the two groups. Inappropriate indications means that the patient had a CTO in an occluded artery with unviable myocardial territory, or the patients had symptoms that not related to that occluded vessel, or the patient had a syntax score with more than 32 with left main, which is an indication for surgery, or if the patient had syntax score more than 22 with triple vessel disease. So they have compared first the success rate, it was 75% in both groups. They have looked at the 1-month clinical outcome in terms of all-cause death, cardiac death, MI, etc. And you can see that actually there was no difference between the two groups regarding all these parameters. But look at these figures now when they have analyzed the results and looked at the 5 years clinical outcome of those same parameters. You see that actually all-cause death, cardiac death, MI, they were significant in favor of the group who has appropriate indication. They have looked at death, MI, heart failure, and still the same. It's a higher death, MI, and heart failure in patients with an appropriate indication, all-cause death the same, MI the same, and heart failure the same when it was an adjusted analysis or adjusted. The conclusion of that important registry is that we have really we need to be careful in terms of indication, try to avoid an appropriate indication to perform CTO, and that the comparison between the two groups did not appear at 30 days, but it did appear at 5 years. So if you're doing a CTO PCI with an appropriate indication and inappropriate indication, you are not serving your patient, but rather you're harming your patient. Second question, what is the likelihood of success? And for that, you need to look at your patient's demographics, lesion characteristics, operator expertise, and of course, your cath lab setting, the availability of equipment, devices, whether or not you have an imaging modality like IVUS, etc. And back to the SCAR registry, when they have compared the population that have a successful PCR for CTO and those who had a failure, you see that actually the population that have success have a much better outcome. So success of CTO PCI affects considerably the outcome. And Galassi in this trial, he also looked at the same thing, but based on the level of LV dysfunction, and he found actually the same thing. So if you have a failed CTO PCI, then you will compromise your patients with more MACE risk at follow-up. He also found actually patients with older patients and diabetic patients have that higher risk compared to the rest of the population. What he did find in that study, and this is quite interesting, he did actually analyze the success versus failure in patients based on LV function, whether the patients have any function more than 50%, between 35 and 50%, or they have an LV function less than 35%. And surprisingly, he found that actually the most benefit was observed in patients with LV dysfunction with an ejection fraction less than 35% in terms of all-cause death, but also in terms of functional improvement, and mainly in terms of improvement of LV function with a clear here improvement of LV function from 29% to 42%. So don't be afraid of attempt to do PCI in patients with LV dysfunction if the indication is appropriate. Now, of course, there are traditional angiographic predictors of poor outcomes. So you know already, if you look at the the anatomy, whether or not you have a high success probability or not to cross and to perform successfully the procedure. Those predictors are long gap, no tapering stump, side branch at conclusion, at the site of the occlusion, vessel tortuosity, calcification, osteal location, poor distal vessel visibility, and bridge scores. The most famous score is the J score that you certainly, the JCTO score that you certainly know. But are there a whole list of other scores, the CT Rector score, CL score, ProCTO? I think you have to rely to one single score in order to determine the probability of success of your procedure. There's also the OroCTO Kessler score. I would not go through the details of that. I would just straight to something quite interesting that was published quite recently, which is a consensus manuscript. There was one American manuscript that was published in circulation, but there is, in the same time, there was another European expert consensus document. And I will just give you just a sense or an idea about both. Let's start first by the American expert consensus document. 7 key principles were really emphasized. The first one is that the principal indication for CTO-PCI is to improve symptoms. Dual coronary angiography is really important. Use of catheters also. There are 4 CTO crossing strategies: the antegrade wire escalation, antegrade dissection reentry, retrograde wire escalation, and retrograde dissection reentry. I would not go through the details of that. The change of equipment and technique increase the likelihood of success and improves the efficiency of the procedure. And importantly, centers and physicians performing CTO-PCI should have the necessary equipment, expertise, and experience to optimize success and manage complication. Now, this is the European consensus that was published almost at the same time. And the European consensus, in the European consensus, there are more details in terms of expertise. For example, it is clearly shown that that at least 100 CTO-PCI per year must be performed by an operator to reach a success rate more than 90%. So really important. And it is recommended that centers and operators performing fewer than 30 CTO procedures annually, they should refer their CTO patients to a more experienced operator. Now, regarding the retrograde approach, a minimum of 50 retrograde procedures, 25 as second operator, and 25 as first under supervision might be advised before a cardiologist becomes an independent retrograde operator. And again, a very important point regarding the leadership and whether you should have several operators in the cath lab, or maybe you have to designate 1 or 2 operators in the team in order to improve the expertise. Third question, what is the approximate cost of the procedure? This is an important question, particularly coming from our environment in Africa and with limited resources countries. And this question was addressed very recently in a manuscript about the Open CTO registry, which is an American one. And what it was shown is that the procedure is quite long, 120 minutes, 3.4 in average guiding catheter were used per procedure, 10 guide wires, 5 angioplasty balloons, 2.6 stents, and the cost of approximately $15,000 US, which is a huge thing, particularly if you compare that to what we can afford in our continent. Let me give you an idea about how we face that problem in clinical practice. This is the case of a 50-year-old man who had an inferior MI with successful thrombolysis, an ejection fraction of 55%, which is not that bad. So there is not much damage to his myocardium with limited inferior akinesia. Coronary angiogram shows severe stenosis of the RCA and proximal LAD CTO. The decision for CABG was taken, but the patient has declined to go to surgery. This is the anatomy. You can see here the occluded LAD with just a poor runoff. You see it barely here distally. This is the right corner artery, which was open, but with a very ulcerated, severe lesion, and it gives a very nice collateral circulation to the LAD. So we started by treating the RCA, and then we tried actually to open autograded LAD, but it was not possible at all. And then we have to decide to go retrogradely through the freshly treated RCA. And you see here, look at this wire going back from the right corner artery, and then it was externalized later on. And then we, of course, we continued after that. It was quite easy later on with a very final good result. Now, we did evaluate actually such procedure that we did perform with Dr. Satoru from Japan. And, you know, this is what we had to use as equipment: 12 wires, 2 microcatheters, 320 ml of contrast, 4 DES.
Wow.
And basically, we did use actually what we usually use in 4 conventional PCIs. But, you know, don't worry, that's not the classical scenario, and didn't happen that way all the time. Quite often, by the way, it's just 1 wire, 1 balloon, 1 stent, as it was found by a recent trial. Where actually in two-thirds of the cases, that's what you need. A balloon or a microcatheter, of course, in addition to that. And this is just quite another case where you have an occluded RCA due to stent thrombosis, quite old actually, and we needed just to have a dual injection in order to try to see where the RCA is, and the distal runoff, 1 wire, 1 balloon, and final good result. I will finish with an algorithm that was published quite recently. So in the presence of a CTO case, if the patient is not symptomatic, medical management is recommended. If the patient is symptomatic, now you have to look if the patient has a multivessel disease or not. If there is if there's no multivessel disease, a CTO, of course, is indicated. But if there is a complex anatomy, then you have to look whether or not the patient is a good surgical candidate. In that case, you have to send the patient surgery. If not, the patient can benefit from a percutaneous approach with CTO PCI. Now, if there is any other indication for surgery, like for example, stenosis or any other reason for taking the patient to surgery, of course, that's a clear indication for CABG. Now, in conclusion, appropriate indication for CTO PCI is essential to maximize the benefit for the patient. Success of the procedure makes a lot of difference compared to failure, and impacts considerably the outcome, and patient's demographics, lesion characteristics, operator expertise, and availability of equipment materials are the 4 cornerstones of success of CTO PCI. Thank you for your attention.
Thank you, Habib, for this excellent presentation of CTO. Is there a question?
Excellent presentation, Habib. Very important concept. You have to have a good indication. You have to have an expert team. You got to be prepared to spend a lot of material. Beautiful summary. Very nicely done. What we did in Washington, it was 10 operators in a cath lab. Many years ago, we assigned 2 of them to do all the CTOs. So we all stopped and assigned these 2 younger people. And they always worked together, every CTO. So they became true experts. And they, what I say, they used a different language and different tools, because it's almost like a different specialty. And that makes, which is what you explained, Habib. So in your sites, I recommend that too, that in your milieu, that you choose a few people to, you know, 1 person per team, ideally, to do the CTOs. 1 or 2, yeah.
Yeah, Gus, absolutely. I completely agree with you. You know, when you started working in the cath lab several years ago, we were 1 or 2 actually doing everything, CTO, but everything.
Right.
And I can tell you that No, true. I mean, and the success rate was quite high. We spent 2 or 3 hours with, 1 or 2 wires. You have to finish the case with success. And then what happened? We had many of our colleagues that went to France for training, to Europe in general, and they came back, and we are several of them. And young interventionalists, they want to do everything too, and they started doing CTO, and we have seen very clearly dropped dramatically, 85% up to 60%. And then we decided very recently to say, okay, we have to organize ourselves now and to do what you exactly said. So we have to be 1 or 2, maybe 2. There are 2 to do that procedure, and preferably to have 1 day for CTO. Because when you do CTO procedures and you have 1 single cath lab, you just cannot do the rest because you cannot organize the activity of the cath lab with CTO. So we say, okay, this is CTO day, or you start from 8 up to, 6, 7 p.m. Okay, I think we're right, and I will now ask Nisma, Dr. Nisma Bendagha. Nisma Bendagha, guys, maybe you don't know her. She's a rising star actually, in Morocco, but also in North Africa, an international cardiologist. She's the daughter of Professor Naim Al-Haytham. Naim Al-Haytham, you know her. She's a pioneer. She's a pioneer on interventional cardiology, and particularly on mitral valvuloplasty, very well known everywhere. So we are really happy and glad to have Nisma now doing the same thing, by the way, interventional cardiology widely, but also she's doing mitral valvuloplasty. So Nisma, you will be presenting to us the take-home messages from these different topics. Nisma?
Thanks, Mr. President. My part in the joint session is to present take-home messages. The first presentation was paravalvular leg closure, indications, techniques, and outcomes. This procedure concerns severe patients in cardiac heart failure and or hemolytic anemia with high surgical risk. And this procedure must be exercised in experienced centers because it's long and complex with multiple devices. Teamwork will select the right patients. Preparation of the procedure includes efficient imaging of the leg with 3D TEE and CT, and precise location, size, shape, severity, and number of leaks. This imaging allows to prepare the materials, choice of devices and sheets. During the procedure, access can be transseptal, transfemoral, and rarely transapical because complications. Crossing the defect with 3D TEE important step. Then release of the device must avoid interference with valve leaflets. We have risk of failures, 10%, and complications are valve interference, stroke, hemolysis, and embolized device. But this procedure is more safe than surgery. The second presentation was management of percutaneous interventions in high bleeding risk patients. Development of new generation of DES permits shortening of the DAPT during high bleeding risk patients. We prefer radial access. Gastrointestinal protection is systematically prescribed, and clopidogrel is recommended. We have 3 clinical situations. The first one is PCI and chronic coronary syndrome in high bleeding risk patients. We prescribe 1 to 3 months DAPT, then long-term single therapy. The second one is PCI and acute coronary syndrome in this population. We give as 6-month DAPT, then long-term single therapy. And the last one situation is PCI and atrial fibrillation in high bleeding risk patients. Prescribe 6 months NOAC and 1 antiplatelet, then long-term NOAC. Next slide concerns latest innovations and new indications of TAVI. TAVI is now the gold standard to treat severe aortic stenosis. This is the optimal choice for degenerated prosthetics valves. Expanded indications being evaluated, like asymptomatic aortic stenosis. Experienced operators are required. Current results show high success rates and low morbid mortality, and improved devices are always being developed. But pending issues with TAVI are needing for pacemaker, stroke, and vascular complication. Yet, some questions remain regarding anticoagulation after TAVI and coronary access after TAVI. Finally, long-term follow-up is not yet available. The last presentation was PCI for CTO, current indications and techniques. Appropriate indication of CTO PCI is essential to maximize benefit for the patient. The 4 cornerstones of success of CTO are patient's demographics, lesions characteristics, operator expertise, and availability of materials. Success of the procedure makes a lot of difference compared to failure, impacts considerably the outcome. Thank you for your attention.
Thank you. Very nice summary.
Thank you very much.
All right, Habib. Thank you again for inviting us, and Samir.
Yes.
Thank you.
Thank you. Thank you so much. I see Professor Aouad joining us. I will let her give the last word. But for me, I think it was a great session. I did really enjoy it, and I hope you did too. Many thanks, of course, to Professor Aouad. Thanks to Professor Aouad and to the board of the Moroccan Society of Cardiology for inviting us to be part of this important thing that was conducted in such difficult times, such a challenge. And congratulations, Aisha and your team, for being able to do this. And now, many thanks also to you, Gus, for your continued support all the time, to our Sievert, to Professor Chaara, to Samir, and to Nisma for sharing with us. And of course, to all the attendees who were able to share with us this session. Aisha, the floor is yours to close the session.
Thank you very much, Professor Gamra. It was a good pleasure to be with you. And I hope that next year we can organize this Congress, the joint concept between the Moroccan Society of Cardiology and PAFCIC face-to-face. Thank you so much.
Thank you, everyone.
Thank you again.
Thank you.
Congratulations.
Thank you, guys.
Bye-bye. Bye-bye.
Bye.